Hello everyone, welcome to Raaonline. I am Dr. Abinaya. I am a consultant pediatrician. So in Nelson-based pediatric teaching, the next topic of discussion is on cystic fibrosis. So I have divided cystic fibrosis into two parts. The management part alone will be in the part 2 of this presentation. Okay, so let's get started. So cystic fibrosis is a progressive disease and progressive multi-systemic disease. So we are dealing in the respiratory system because most of the systemic features actually start and the predominant complications or the predominant symptoms pertain to the respiratory system. So I have placed cystic fibrosis in under respiratory system. So this is a very progressive disorder. It is a genetic disease which is inherited as an autosomal recessive disorder. So this causes a persistent lung infections and respiratory failure also happens over time. The phenotypes of cystic fibrosis are very variable. Most of them have the respiratory symptoms. Some can have a normal sweat chloride, some can have a high sweat chloride, some can have more of a GI manifestation, some can have lesser GI manifestation. So it is a very variable phenotypes among the children. It definitely causes severe morbidities and reduces the quality of life in these patients. So the main cause of death in cystic fibrosis happens due to respiratory failure. We will see how and why in the presentation. So physician Dr. Dorothy Anderson was the first to discover cystic fibrosis, and she described in the year 1938. So she described cystic fibrosis among a set of patients which involved the pancreatic ductal function. Okay, initially it was described in the pancreas. So she discovered way back in the year 1938. So meanwhile, from over these years, over the last 30-40 years, the prediction, the survival age of cystic fibrosis has dramatically increased. Maybe because of the awareness, because of the better prophylaxis of the drugs, better understanding of acute exacerbations and immediate responsive treatment that we give to these children, the chest physiotherapy, the mucociliary clearance techniques, etc. So maybe the comprehensive treatment that we have started providing to these patients has improved the survival. So as you can see here, around 1990, the survival age was somewhere between 28 to 32. So towards the end of the third decade, it slowly increased, and now in 2017-2021, the survival age of these patients, cystic fibrosis patients, has increased up to the 5th decade. So it is a dramatic improvement, isn't it? So understanding of cystic fibrosis patients and treating them, attending to their concerns, a holistic management is very important. And I am sure you have all seen cystic fibrosis patients. But if you are a treating physician or if you are a primary physician, identifying and getting the genetic study done and getting the sweat chloride, at least even suspecting that this could be a cystic fibrosis is definitely welcoming. So that is where the first point of care, a practicing pediatrician or a general pediatrician is the one whom the cystic fibrosis patient comes to first, isn't it? So we have to suspect CF, do the investigations and immediately refer them to a center which has a CF expertise. So coming to the incidence of cystic fibrosis, it actually varies. It is highest in the Caucasians, that is between 1 in 2500. So this is the highest. In the Indians, mostly there are no Indian studies, but studies which have included Indians are mostly NRIs in UK and USA. So the incidence is between 1 in 10,000 to 1 in 40,000, and it is low. I mean, most of the time it is the lowest incidence among is in the Oriental population. So highest in Caucasians and around 1 in 90,000 in the Oriental population. In India, the precise incidence is not known. So let's talk about the CFTR genetics. Let's talk about the CFTR protein. Let's understand why or what function does the CFTR protein does and why are the manifestations different for each individual. So the CF gene, the cystic fibrosis gene, encodes for this CFTR protein. The CFTR protein is a large protein which has around 1480 amino acids, right? So this CFTR protein is expressed in many sites in our body. So let's see what are these sites one by one. So first is the epithelial cells of the airway. So this is why when the CFTR protein is mutated, it results in an impaired mucociliary clearance. Okay, so it is expressed in epithelial cells of the airway. Second, it is expressed in the pancreas. So it causes viscid secretion in the pancreatic ducts, and that causes pancreatic duct obstruction. So we have to replace all those pancreatic enzymes are not coming out. So we have to replace the pancreatic enzymes from outside. Next, it is expressed in the biliary glands. Cystic fibrosis is associated with primary biliary cirrhosis. It is expressed in sweat glands. So we use the sweat chloride level for estimation, for identification, or for the diagnosis. It is in fact the gold standard test. Sweat chloride test is the gold standard for cystic fibrosis. It is expressed in the genitourinary system, so that can result in infertility. In male, infertility is because there is going to be a bilateral absence of vas difference, and in the females also it can result in subfertility. So now you understood where all the CFTR protein is expressed in the human body, and each has a different, not exactly the same function. Each has quite a different function. So it tries to, it acts as a chloride channel. I'll tell you why it happens, and in different systems. Okay. So you saw where all it is expressing, right? The CFTR is a member of the ATP binding cassette transporter protein. Basically, CFTR, it functions as a chloride channel, and it regulates, of course, when one ion channel, it acts as a one ion channel, it is going to regulate the hydration of the mucus. So it's going to regulate the air fluid level. It is going to regulate the sodium levels in the sodium chloride levels in the sweat. So many other regulatory functions are also responsible by the CFTR protein. So there are many polymorphisms, more than 1900 CFTR polymorphisms which has been described till date. But the most prevalent mutation worldwide is the delta F508. So delta F508 is nothing but the deletion of a single amino acid residue, that is phenylalanine residue is deleted at the position of 508. So this is the most prevalent or the most common cystic fibrosis mutation. So let's move on. So there is the CFTR protein. So CFTR is basically a complex protein. So this is a CFTR protein. So this functions as a chloride channel. It's a complex protein. As you can see here, there are 5 domains basically. Okay, 5 domains. These two, this is one domain. This is a membrane spanning domain. This is also a membrane spanning domain. So basically there are 2 membrane spanning domains. Here you can see this is one nucleotide binding domain. There is another nucleotide binding domain here. So 2 membrane spanning domains, 2 nucleotide binding domains, and 1 R, that is one regulatory domain. So this is the CFTR protein structure. So normally the mucociliary, this is the mucociliary layer. Okay, so this is the respiratory epithelium which contains cilia. So above this layer, so this is a serous layer. Above this there is a mucus layer. So the mucus layer will contain the trapped particles. This cilia which is propelling forward, there is regular ciliary beating, and the ciliary frequency, everything will be normal. The pattern beating, everything is normal. But what happens in a CF patient? This mucus becomes very, very dehydrated. So this is a CFTR protein. It basically acts as a chloride channel. Here if you pay attention, you can see that there is an epithelial sodium channel or ENaC channel, isn't it? So this is ENaC, this is CFTR. This ENaC channel will absorb the sodium into the cell. Okay, so sodium is absorbed, and the chloride from here into the cell will be secreted outside. So the sodium absorption and chloride secretion will regulate the airway ASL height and the ASL composition. So what happens whenever this CFTR is mutated? So the CFTR mutation is present. The chloride function, the chloride channel function doesn't happen. So this ASL liquid layer will become very much dehydrated. All the dust particles, the organisms, the pathogenic organisms, everything will come here. So they get colonized, the entire airways get colonized. The cilia also will not be able to function properly. So because of the impaired mucociliary clearance, these patients will be at repeated risk of bacterial infections. So let's again see what is happening in a normal CFTR if the normal CFTR protein is present and when the CFTR is mutated. So this is a similar image what we saw in the previous slide. So here you can see that this is the epithelial sodium channel. This is the chloride channel. Okay. So the sodium is reabsorbed into the cell. The chloride is secreted into the lumen. So when the CFTR protein is mutated over here, what happens? The chloride doesn't reach this liquid layer, that is ASL layer, airway surface liquid layer. So what happens? The entire mucus layer becomes very, very thick, very much dehydrated and acidic. So when the layer, the ASL liquid layer is altered, so that results in a lot of colonization, bacterial colonization, and results in exacerbations of these patients. So these are the respiratory cells, cellular epithelium. So they are all interlinked, as you can see here. Some tight junctions are present, some gap junctions are present. So what happens in these respiratory epithelium? One is absorption, that is sodium is absorbed via this channel, that is the ENaC, epithelial sodium channel. Water is also absorbed. Water can be absorbed through aquaporins. AQP means aquaporin. So water is absorbed through the aquaporins. Again, water can pass paracellularly also. You can see here that is chloride. Chloride is also passing paracellularly. So this is a passive transport. Okay. This again, secretion also happens. I told you CFTR acts as a chloride channel. So chloride will be transported into the lumen. So this is an active transport that is taking place here. Again, through aquaporins, water can come inside, water can be secreted also. So water can come paracellularly inside the cell and it can go outside the cell. When the CFTR protein is mutated, chloride secretion doesn't happen. The water will not be secreted into the lumen. So what happens here to the lumen? The lumen will become very, very acidic because of, so it becomes very acidic, it becomes very much dehydrated, thick and viscid. So basically all these are linked as a complex array of functional proteins. So just remember absorption of sodium, secretion of chloride and secretion of water. So if one doesn't take place, everything will get altered and result in ultimately alteration of the airway surface liquid, that is ASL, airway surface liquid. Okay. So let's move forward. So far we have seen what happens if the CFTR protein is mutated in the respiratory epithelium. So now we will come to the gut. So this is the pancreatic cells. So what happens in the ductal cells? Again, because of the CFTR protein abnormality, the chloride will not be secreted. The chloride ion will not be secreted into the lumen. That will result in a, like in the respiratory tract, in respiratory tract, the secretions became very thick, very acidic, etc. Isn't it? Similarly, here also the secretions will become very, very acidic and viscous. Ultimately, this is going to block the duct. This is the pancreatic ductal cell and this is the duct opening. So it is going to block the duct. So when the duct gets blocked progressively, there is leading to inflammation and that finally will cause the acinar cell injury. So these are all the cells, this is the duct. Okay, so the acinar cell epithelium is completely injured progressively. So this is why this is taken as a screening test for newborns. So in newborns, we do the immunoreactive trypsinogen. So we do IRT as the newborn screening test. So I will explain about IRT in the towards the end of this presentation. Okay. So we will this presentation, this particular slide is a general slide. So how a protein is made. Okay. So we all know initially for any protein to be translated, any protein to be made, first we need the information from the DNA. Okay. So the CFTR gene will give instruction to make the CFTR protein. The RNA will act as a template to make the protein. From DNA, RNA comes by matching the instructions. That process is called as a transcription. And the ribosomes are the tiny molecules that will read the RNA and then it will translate into the CFTR protein, that is called translation. Once it is complete, the CFTR is made and it will be moving to the epithelial surface. So that is called as a trafficking. Once it reaches the cell surface, it will help in the chloride channel it will function as a chloride channel and help in the chloride transport. So this is nothing but how a protein, any protein is made. So you know transcription, translation, trafficking, and then finally that protein's function will happen. So nothing new in this. So this is just the pictorial representation. So this is the CFTRC, this is the CFTR gene. So that gene gives information to the DNA. DNA is transcribed to the RNA. Through the ribosomes, the RNA will translate it into proteins. So a mature CFTR protein is formed. This will go and reach to the epithelial surface now, and finally it will act as a chloride channel and chloride will be secreted. Okay. So we have the many different classes of mutations. So anywhere the mutation can attack, and based upon the classes of mutation, our therapy also will vary. So we know about the basic things that we do in any child with CF, the physiotherapy part, to increase the mucus clearance, we give antibiotics, etc. But now there are a lot of gene therapies which are coming up, which are going to target on which class of mutation that particular patient has. Okay, I will explain you will understand. So there are basically 6 different classes of mutations. Among all this, class 2 is the most prevalent class of mutation worldwide. Okay, so in class 1 and class 2 are basically severe mutations. So you see here, class 1 mutation, so this is the epithelial surface. Okay, this is the normal, so this is the normal CFTR protein. So here you can see that it is present in the epithelium and chloride channels, it acts as a chloride channel and chloride is getting secreted. So what happens in class 1 mutation? Absolutely there is no CFTR protein at all. So you can see that the epithelium is plain. There is no functional CFTR. So this is the most severe of all classes of mutation. Next, in the class 2 of mutation, so what happens is there is this, yes, so what happens is here the CFTR protein is formed, but it is misfolded, and so it doesn't go and reach the epithelium. So you can see the CFTR protein over here. So it is a misfolded CFTR which does not reach the epithelium. Apparently here also there is no function at all. Okay, so here it is a missense mutation. In the class 1 it is a nonsense mutation, where here it is a missense mutation. Class 3, you can see that there is a CFTR protein, as you can see, isn't it? You can visualize a CFTR protein, but there is no function. It doesn't function as a chloride channel here. So it basically reaches the epithelium, but the channel doesn't work. So defective channel regulation. Next, going to class 4. So in class 4, the function is open, but the conductance is not normal. So the conductance is decreased. The decreased chloride secretion happens here in class 4. So class 5, some amount of function happens in cystic fibrosis patients. Okay, so this is a scarcely functioning CFTR protein. So class 6, what happens? It functions, but it is not stable. Okay, so the stability is decreased. So these are the different classes of mutation. Class 2, which is severe mutation, is the most prevalent one. The trafficking abnormality is the most prevalent one. Okay. So next we will move on to the pathogenesis, some of which we have already seen, isn't it? So the mucus secretions will not be able to clear. The mucus secretion will be very, very viscid because of the paucity of water. Salt content, that is the sweat chloride level, will be high, and there will be chronic infections in the respiratory tract. So why there are infections? Why the patient has a chronic infection in cystic fibrosis? So these patients, they will not be able to clear the bacteria promptly. We know that the airway surface liquid is not normal here. The secretions are very, very viscid, and so the ciliary clearance, the cilia also will not be able to function normally. So because of this, the inhaled bacteria will not be cleared. And of course, the secretions will be very, very acidic, and because of the acidic nature, whatever innate immune response, so the secretory IgA, all those innate immunity will not be able to function normally. So there is also a lipid homeostasis which is altered. There is a very high arachidonic acid and a low docosahexaarachidonic acid in these individuals. So this ratio will promote inflammation in these patients, So ultimately what happens, cystic fibrosis patients will have a persistent infection and a persistent inflammation limited to the respiratory tract. So these chronic infections I told you, and cystic fibrosis patients have a specific predilection to certain organisms. So not the regular ones, and all these organisms are going to be highly resistant to our antibiotics also. So let's see what are the chronic infections in cystic fibrosis patients. First will be Staph aureus. Next will be Pseudomonas aeruginosa. In one another presentation, I was mentioning that in case if you get a bowel fluid analysis which is showing Pseudomonas aeruginosa, definitely you have to rule out cystic fibrosis, because these patients, colonization with Pseudomonas is very common. Next, Burkholderia cepacia. So the respiratory colonization with Burkholderia cepacia will lead to a high mortality. So if we if any analysis shows, if bowel analysis shows Burkholderia cepacia, we have to be extremely careful and treat the patient very promptly. So these are the most common organisms which will infect the cystic fibrosis patients. These organisms rarely infect normal individuals. Of course, Staph aureus can be there, but the other two, Pseudomonas and Burkholderia cepacia, can rarely infect normal individuals. So this causes a vicious cycle. It causes infection, it causes inflammation, mucus production will be there, obstruction, bronchiectasis, and finally respiratory failure. So this happens as a vicious cycle. So once an infection is established, this is going to happen again and again. Before, in India, we don't have the newborn screening for cystic fibrosis. Okay, so how are we going to suspect? So I told you cystic fibrosis is a multisystemic illness. I will talk about what are the respiratory complications first, or the respiratory clinical features first, then GI, and then genitourinary and biliary ones. So for respiratory, I am going to tell about one thing, that is first will be bronchiolitis. So most of the cystic fibrosis children, that is up to 80% of the children with cystic fibrosis, will have at least one episode of bronchiolitis before their first birthday. Very important. So in case you diagnose a child at 3 years or 4 years and you ask them about a past history, definitely they will tell one hospitalized admission for bronchiolitis before 1 year. So it is very common. Apart from bronchiolitis, there can be bronchitis, there can be pneumonias, there can be bronchiectasis in case we diagnose very late a child at 5 years, 6 years, which is quite uncommon nowadays. Nowadays, pediatricians have really good awareness, and the age of diagnosis is actually less than 3 years nowadays. So in case the diagnosis has become very late, bronchiectasis will result, and finally that will go for respiratory failure. There can be atelectasis, hemoptysis, pneumothorax, and upper airway involvement is also there. So these children can have nasal polyps, sinusitis. So just like our primary ciliary dyskinesia, so primary ciliary dyskinesia also affects upper and lower airway. So these patients can also have nasal polyps and sinusitis, and there is a close association with reactive airway disease. So they may need bronchodilators and nebulizations with bronchodilators. ABPA is one of the dreaded complication of cystic fibrosis patients, and we need a high index of suspicion. Whenever there is an acute exacerbation, whenever the patient deteriorates, after ruling out an acute exacerbation with some infection, we have to always think of ABPA in children with cystic fibrosis who are more than 5 to 6 years of age. Less than that, it is very uncommon. Okay, so these are all clinical respiratory system clinical features. So I told you in the very first slide, the cause of mortality in cystic fibrosis patient is going to be because of respiratory progression only. So pulmonary exacerbations we have to keep in mind always. So whenever a patient, you know the baseline of the patient. Okay, so you have identified some symptoms, you know the typical symptoms of CF, you have diagnosed the patient. In case from his baseline, if the child is becoming increasingly sick, like fever, cough, respiratory distress, so much of secretions, hemoptysis, so any acute deterioration in these patients, we have to think of a pulmonary exacerbation. Okay, so pulmonary exacerbations has to be treated promptly in these patients. On examination, cystic fibrosis patients will have an increased AP diameter of the chest because of the hyperinflation. So like a bronchiolitis child, it is expanded, the AP diameter will be expanded. There will be generalized hyper resonance, and there can be crackles, So, because it is a suppurative lung disease, there is bronchiectasis, so patients can have clubbing, pallor, and there can be wheeze. Cyanosis is of course a late complication in these children.